Welcome back. My name is Dr. Dean, and I'm here with
Venzel.
And today we're going to talk about something maybe you haven't ever heard about before, and that's gamma gain.
Exactly.
Okay, and then what we want to do is we want to help you understand how gamma gain is going to fit in with your therapy. So gamma gain in and of itself isn't something that you or I can control, like when we exercise or we move or we're in our sport. It's something that develops over time.
Yeah.
And when movement patterns, let's say in the therapy setting, right? When we teach our patient a therapy, we're trying to like reverse, let's say, a faulty motor pattern.
Yeah.
Or we're trying to correct an injury, right? So a lot of people don't know this, and I get asked this a lot. An injury won't automatically heal back to its optimum or premium biology all on its own. It has to be steered in that direction specifically. So we want to make sure when we're doing a therapy, a movement therapy with our patient, we want to make sure that we're guiding or steering that recovery, that movement pattern into the way that patient uses their body, maybe not every patient, right? Okay, so that's important to understand. And then so what we're going to do today is we're going to build in the story of gamma gain and why it's important in the therapy setting. Yeah. So let's back up a little bit. We kind of talked about this before a couple of times, right? We kind of set up to do this video. And the concept of gamma gain is a little difficult to discuss. So we thought that we would have sort of the challenge of trying to talk about it. And then I'm going to drop in some videos that are like me on the board so that people can kind of see how that works. Okay, so please be patient because we have to get through a couple things first so that the gamma gain story will make complete sense to you, okay? So gamma gain starts, just what the heck is it, right? So the gamma motor neuron is aligned with that alpha motor neuron.
Yep.
Okay, so in the brain, let's say, Venzel says, hey, I'm going to reach out. Okay, so you're going to reach out. So you're, without really thinking about it, too much planning, your brain talks to the muscles, right? And you extend your arm goes out, okay? So we know that as the alpha motor neuron, brain down to the body, right? Something happens.
Top down.
Top down.
Yep.
Yeah. So then the other would be, so it's efferent. So the other would be the afferents, and that would be proprioceptively reading the body, okay? Now, the gamma motor neuron does both. It's involved in the top down, right? That corticospinal, and then spinothalamic, the other direction as proprioception. It's a very special situation, okay? So let's talk about it. So put that on hold a little bit, and then let's get this early part of the video done. Okay, so we have a couple topics we want to talk about. Now, these topics are very essential for just understanding all therapy, right? So we're kind of building that into this video to have more value, right? Added value. Okay, so the first topic we're going to talk about is the therapeutic rationale, and then we're going to discuss how gamma gain fits in with the therapeutic rationale. Okay, so we talked about it and we came up with basically five things that are built into why we do what we do. Okay, so you just take the first one.
So the first one is we want our patients to feel better. So they come to us, the main thing we want them to do is feel better. So our first job is emotionally focus on making them feel better.
Right, so they come to us and let's say they have an injury, or let's say they have a strain, or they have pain, or they have an irritation, or some people have like a stabbing feeling, or dull, achy feeling, right? So we're talking about sort of that sensory place that's
Yep.
annoying them, it's irritating them, it's preventing them from going about their day or getting a
Exactly.
restful night's sleep or being able to concentrate at work or maybe even preventing or limiting them in their sport,
Yes.
right? We're going to talk about that again in a little bit, right? So therapeutic rationale number one is through therapy, we want to help the patient feel better. That's sort of in most settings, the primary goal.
Yeah.
Not so much for us, but it doesn't mean that we don't care. Of course we care. Okay, and the second one I'm going to take, so the therapeutic value number two is attempting to treat the cause. So instead of just treating only the symptoms, which matter most to the patient, we need to add in that, hey, we're going to educate you and let you know why this happened or why it keeps happening, right? So that the patient has that take-home value of being able to sort of manage the situation on their own. Okay, and then
and the analogy that I would use for that is like a pipe. You keep plugging the pipe. That's dealing with the symptom, but you want to get to the root cause of why the pipe keeps bursting.
Right.
So that's the rationale of why you want to attempt to treat the cause.
Yeah, that's a good example. Okay, and then number three?
Number three is you want active patient participation. You want your patients to be engaged. You want them to feel a part of their recovery. If it's all based on you and what you do for them, they're never going to get back to where they once were, or even before where they were, to become a better version of themselves. So your job as a clinician is to get them to do something that they probably have never thought about doing, or they have done it before, but you need to build that relationship back up again and help them stay motivated and engaged in the work, because most of the work is not going to be done with us. It's going to be done out there in the real world. Yeah.
So in the therapy setting, one of the therapeutic rationales is that sort of teamwork kind of concept, right?
Exactly.
Okay, and then number four is to make sure that whatever we're doing is included in their insurance plan. Now, I'm just bringing that up because that's, of course, therapeutic rationale. Why do we choose what we choose to do with them? Because insurance will cover it, right? So what we're just going to say is if we're like, hey, thanks for coming in today. I see you have a knee problem. We're going to work on your gamma gain today. And the patient's going to be like, what are you talking about? Right? And then insurance is going to be like, what the heck? What is that, right?
For that. Yeah.
So the reason why we're bringing up this in this conversation is that the gamma gain story has to get sort of back built into the therapy. And then the last one is?
The last one is you operate within the scope of your practice.
Right. So the rationale would be you don't want to be giving a therapy that is sort of above and beyond
your means or your understanding.
Right, your scope of practice. So staying in scope of practice. Okay, great. So the next thing beyond therapeutic value is we need to really understand the tissue.
Yes.
So when we say understanding the tissue, what we mean is the patient in that sort of primary inflammatory state where, right, we're just trying to calm things down. Of course, we don't ever want to eliminate inflammation because it's part of the healing process. Yeah.
Exactly.
So then we want to know, is it inflammation or is it not inflammation? So what we're most concerned with is discussing with the patient the course of care, the whole course of care before we start doing anything with them. So depending on whether they're in the inflammatory state or not, let's say it's chronic, right, is going to determine the course of care. And what we mean by course of care is the exam, the full treatment plan, and including discharge.
Yes.
Okay? So all treatment plans, or all course of care really, there has to be a discussion with the patient. This is when I'm expecting you to be done, and this is the condition you're going to be in when you're done, and we're going to be both working towards that. Okay, and that's also, understanding their injury, their limitations, of course, pain, things like that. And then, so we're going to back build gamma gain into that
story.
as well. Next, we need to talk about the therapeutic format. So they've been examined, they've been diagnosed, or they've been already diagnosed by another doctor or specialist or clinician or whoever. By the time they come into therapy, they may already have an understanding of what's going to be happening. So like we said before, we want to understand, is this in inflammation or is it not? Okay? And of course, if it is, then we proceed with palliative care to begin. If it's not inflammatory, then we're going to institute care, right? And then, so we want to make sure, and this is where the story is going, we want to make sure that we're steering the patient in the right direction. So when they get that prescription of, let's say, 4 to 12 weeks of care, that during the course of the care, everything is addressed, the pain's addressed, for example, strength sometimes. What else? Range of motion.
Yeah. Active range of motion.
Active range of motion, right. Restoration of ADLs.
Yes.
Maybe like what they call like work hardening, like being able to do your job.
Yeah.
Get back to your sport, right? Social skills, social gatherings, things like that, right?
Yeah.
Some people just can't go like your wedding.
Yeah.
Right? So your grandmother was there.
Yeah.
And she was there, doing her best, but she
couldn't continue to be there because it was debilitating for her.
So then your dad.
Yeah, he had to take her home.
So where were your grandmother and your dad for your wedding?
For the ceremony, they were there, but for the reception, they had to leave. So that missed out on a big portion of the wedding. So they didn't even get to enjoy the full wedding because of that.
Of pain.
Yeah.
Right? And that gets overlooked.
Yeah.
Right? So things like that, because of her health, right?
And then
it isn't just, so the point is, it wasn't just the pain.
Yeah, it is, and it has a psychological component too, because she was sad that she had to miss that.
Right.
So that is affecting her psychologically.
Because wasn't she going to be like in the Macarena or whatever it was?
Cupid shuffle.
I saw you all doing it. That's right. Okay. So understanding the tissue is super important, right? To know how to proceed and how the duration of care.
Exactly.
Okay. All right. So now let's talk about, as clinicians ourselves, okay, we came up with 6 different topics that we want to mention, okay? Yeah. I'll take the first one. Okay. Primum non nocere, which means first do no harm.
Yes.
Okay, now I've talked about this before in blogs and in other platforms. So we're talking about mostly, is the treatment plan and the treatment safe, and are they effective, right? That's what we mean primarily. First, do no harm. Yeah. But I'm going to say, if the therapy is expensive, and I don't mean millions of dollars, but I mean if it's out of their pocketbook, that's doing harm.
Yeah, economic harm.
Right, financial harm, right? Or it's limiting their ability to get better.
Yeah.
When the clinician or the office, the clinic office, is more concerned with getting paid for all of the sessions that are approved, right? Then they're kind of delaying and stretching the care out because they want the money, right? They're thinking about the profits.
And sustaining the building, and what do I have to project, which is, and the business side, it makes sense, but your business needs to match up with your morality and your ethics. So that's a key that I believe in, is the whole tenet. How you conduct business should align with your ethics and who you are as a person and an individual.
And with patient values.
Exactly.
And their ethics.
Because they pay attention to that.
Right. So I'm just saying that, yes, it's about safety, yes, it's about effectiveness of the treatment plan itself, but it's also doing no harm means that if you can get the patient better faster, which has to do with gamma gain.
Yep.
right? If you get them better faster, even in, I'm just going to say for the 100th time, one treatment, right? If that's possible, and maybe it and could be,
Possibly, yeah.
right? Then that's removing harm, right?
Yeah.
And then also for, treating patients for personal gain would be doing harm as well. So doing harm isn't always about the experience of the patient being uncomfortable, or that the therapy hurts, or maybe the hot pack's too hot, or the ice pack is too cold. We're not talking so much about that as what kind of harm is the clinician or the practice or the office overlaying or overlapping into that first do no harm.
Exactly.
Okay.
And then going into, you mind if I go to number 2?
Yeah, go.
Number 2 would be you want to be sociable, friendly, and approachable. So if you're going to be in the clinic, you need to foster a friendly, you should have a friendly demeanor and an opening demeanor, so the patient feels like they're safe, because you're unknown to that person. So naturally, just going to the doctor makes people more apprehensive. So even in testing, like running tests and doing certain, like if you're looking at gait, looking at a plethora of tests, it's going to be slightly skewed, because you're not accounting for that nervousness, that
that's
tension,
so true.
that tightness
Yeah.
that people feel when they go into an office and they don't feel relaxed and they feel like, oh, I'm on edge. It's just naturally apprehensive that makes you even tight, just as a person. If like you didn't know me, and I just started saying all this stuff to you, you would naturally feel like you want to get tight, small, and just you want to protect yourself. So a more protective shell. So your body's going to do that. Just like an injury, your body goes into a protective shell once you're injured. And the way we talk about with gamma gain and ground force reaction is how we work ourselves out of that. But that ties in with the friendly approach. So just from the approach of how you deal with your client can dictate how well the patient outcome can be.
And affect gamma gain.
Yep.
And you still don't know what it is.
Yeah.
And now we've talked about therapeutic rationale and its relationship to gamma gain, and understanding the tissue and its relationship to gamma gain, and therapeutic format and its relationship to gamma gain. And now we're talking about like these 6 categories as clinicians, and we're going to see in every single one of the 6 is a component of gamma gain, right? So we're kind of teasing you a little bit, aren't we? Okay, the next one, as clinicians, we need to monitor or respect sort of the educational value, right, of the situation.
Yeah.
How much does the patient know about their body and their injury? But also, what do we know? What are our credentials as clinicians? Do we truly understand, let's say, for example, and you've heard me say this before, my doctor is super cool, my personal primary doctor. He's super cool, but he has no idea what to do with low back pain.
Yeah.
And that's not okay. I'm just saying. So he could improve his knowledge set on his understanding of low back pain. So what we're saying is, if the patient comes in and they've got an injury and the clinician, like, I think I can help that patient. It should be,
I can help that patient.
just like he said, right? So this is scope of science, scope of practice, I'm sorry. Understanding science, right? And then, of course, don't make stuff up. If you don't understand the diagnosis, the injury itself, the treatment plan, don't make anything up. You need to raise your hand in your office and have some support. Turn that into, I'm going to say, a really big teaching moment, maybe even staff-wide, and make sure that, once a week, that office is digging into the knee,
Yep.
digging into the hip, digging into depression,
Yep.
digging into anxiety, right?
Exactly.
Not just physical injuries, right?
Yep. And communicate, because communication is key. And especially in the aspect of what you're saying is because you can communicate that something you might not be that well versed on, and you'll find a resource, or you would do the research yourself and get that information to your client. You don't have to show that you don't know. Everybody doesn't know everything, so you don't want to give that impression off.
Right.
Yeah.
And that's a really strong point. Okay, and then the next one, number 4. Oh yeah, this is a good one, and we actually did our homework.
Yep.
So let's hear about it.
So number 4 is you want to be compassionate and empathetic.
So what we're addressing is as clinicians, there's an emotional component
Exactly.
that is relating to the patient from from the clinician. So let's hear about it.
So I want to first talk about empathy before, because I know compassion is first, but I'd rather start with empathy.
Yeah.
Empathy is understanding what the patient is going through, and it doesn't necessarily have to be directly related to that injury, but that emotional component of what if it's stopping them from doing something that they love. You could relate to that because everyone has gone through a situation like that, and tying in like that need and reading the person. If you can empathize with the person, that's going to increase your that emotional connection with that person. So now there's an emotional tie that allow that treatment. So even if they are more apprehensive, they trust you. They see a link, and they see that you can empathize what they're going through. They're more likely to do the said movement or said pattern or whatever you have set for them to do therapy wise. And then the compassionate part.
Hold on. And it's more meaningful.
Yes.
If the clinician experienced it themselves.
Yes.
And they relate, hey, I get it, your knee hurt so bad. I had a very similar situation happen with me, and I wanted to get better as fast as possible. And so guess what I'm going to do for you? I know how bad that is. And, I wanted to go mountain biking. And I couldn't because of my knee. And I love to mountain bike.
Exactly.
What is it that you like to do and is holding you back from your knee? Right?
Example, I like to run.
Right. So, hey, we're both, right? And it's exactly what Venzel said, is that empathy is understanding from a personal experience, and not only just understanding it like on your side, but relating to the patient, because now the patient, like you said, will assume that because you've had that experience, you're going to want to help me more because that's what you would want for yourself. Exactly. Yeah.
And then the compassion part ties in specifically because, and I use compassion synonymously with sympathy. So that's a feeling of, pity, or you feel bad for that person, but it comes with action. So to be compassionate, it has an actionable part in it. So with empathy, it's that understanding, but not necessarily doing something about it. So it's creating that emotional connection, but the compassion is what allows you to do something about it. So if you have the compassion plus empathy, it's holistic in its approach. Like it's complete. So compassion plus empathy allows you to treat the patient in the most optimal way, from a psychological component as well.
Right. And so the reason why we picked this category, that sort of emotional part, is so that we could discuss compassion and empathy and have this sort of defining moment, so that that's added value.
Yes.
Right? Maybe you knew about it, maybe you didn't, maybe you just care about your patient and you just care. But I'm going to say you could turn the dial up. You could elevate your experience with the patient by taking 5 seconds, 10 seconds, and saying, hey, you know, I had a knee injury too, right? How long does that take? But the value that it builds, and it just, it escalates or it elevates the ability for the two to relate.
And guess what? That's another sneak peek into Gamma Game because of that symbiotic or synergistic.
Synergistic.
Yeah, synergistic relationship between compassion and empathy.
Right. So remember what he just said, because it didn't occur to me until just when you said it. I was like, nail, hammer, perfect. Yeah. Okay. So that's coming. It's just hang on. Okay, and then the next one is, as clinicians, we need to be concerned, of course, with the economy of our treatment plan or whatever it is that we're doing. It must be accessible. And what we mean sometimes is that it needs to be financially accessible. It needs to be within the resources of the patient. So we can't ask them, you know, to do a home therapy if they have to spend a bunch of money on something, or they don't have a gym membership. Then we need to tailor the workout, and the workout can't be only them coming to therapy.
Yeah.
It also has to include them, like you said in the very beginning, what they can do at home, so that it's not necessarily all just home exercise, but home-based awareness, right?
Yes, exactly.
And then, of course, the drill should match the aptitude. You wouldn't, if you had a high-level athlete, you wouldn't start off with, you know, dead bug. Right, and we all know how I feel about dead bug. Okay, and then of course there's skill level. Yep. Okay, and then the last one is
it must be systems based.
And so what we mean by systems based is that we want to integrate the therapeutic value, the therapeutic format, understanding the tissue, and understanding, you know, these 6 components as clinicians. They all have to go together, right? Work together. It isn't just the patient has a problem, and that's the beginning and the end of our understanding of the whole.
And you just tell them exercises to do, and expect them to just do those, and then consistently do those when they're awake.
Right. Yeah. Okay, so now let's dive into gamma gain.
Yes.
Okay, and then we're going to show you why we took the time to kind of explain our way through these factors. Gamma gain basically describes the body, the movement body, and the brain's central control working together synergistically.
Yes.
So, for example, the brain sends a signal, you know, spontaneously out into the body, just commands the body to do something. We, of course, have muscle contraction, right?
Yes.
So we have type 1 fibers, we have type 2 fibers,
Exactly.
okay? When those muscles contract, the two ends of the muscle come together, and in a fraction of a hair of a flash of a sub-second, there's slack in the muscle.
Yes.
Right? So if I have a towel stretched out between my hands and I contract the muscle, right? The towel comes together. The towel's going to sag.
Yes.
Okay? So what gamma does is, as the muscle contracts, it kind of creeps along and keeps the muscle taut and tight, right? Which speaks to the muscle spindle, which understands then the speed of the shortening of the muscle, and then Golgi tendon organs are also feeling that uptake of slack.
Exactly.
So the job of that gamma in that whole experience is basically to uptake the slack to keep the muscle toned.
Exactly.
So that as it contracts, it's contracting in a way that speaks proprioceptively accurate back up. So when he said it's a lot like compassion and empathy sort of cycling together, right? We can't really have one without the other and not be successful.
Loop, and that's what that gamma loop
Gamma is also a loop, so it depends on that top-down, that motor command, and the proprioceptive feedback.
Exactly.
It's perpetually in that loop. So when we want to understand gamma gain in the therapeutic realm, is gamma gain has to be taught.
Yes.
It's an educational component within every drill. So when a muscle is firing slowly, gamma is basically turned off because the slack is almost imperceptible in a slower movement. When a muscle contracts quickly, gamma has to fire fast.
Exactly.
And it has a faster job to do, right? So I could say, like, let's say we're throwing a football back and forth to each other, right? If I really sling one at you, that contact point requires much more focus, agility, exactness, and reverse force.
Exactly.
Right?
Yeah.
Whereas if I just, kind of lob it to you, all of those things are turned off. Okay? So what I'm saying is, we backtrack into the first part of our conversation, is when the therapy is slow, moving, and there's just like, hey, I want you to just do a knee extension, right? So let's say it's a knee complaint, and we're just going to do, so just move through this range of motion, try to straighten your leg all the way out. Gamma is turned off. When gamma is, like, we'll call it in that negative state, it doesn't mean that it's not happening. We're just going to say it's slow. So we're going to call that negative gamma gain. Negative gamma gain. Okay? When that action is slow, proprioceptive feedback becomes slow.
Yes.
And that's a problem.
Especially,
Because that's delaying treatment progress.
it prolongs it.
It prolongs it, right?
Yep.
So we could almost say that falls into doing harm, right? We talked about that as clinicians. First, do no harm. We could almost say delaying their care is harmful to the patient.
Yeah.
Now, we don't mean we're not hurting them.
Yeah. And
But-
and not even saying that the clinicians who might do that are purposefully doing that, and might just
They're
be,
not.
They
don't know about gamma gain.
Yeah.
So what we're saying is, if your therapy patterns, and you can see this over and over in a lot of our content, over and over and over, acceleration into deceleration, quickness, suddenness, right? That almost, we've said this before too, the faster you move, it's almost the more core is required when the movement is fast. When the movement is slow, gamma gain is, we'll say negative or slow. The proprioceptive feedback is slow, and core recruitment is diminished, right? Or maybe even not present at all.
Yeah.
So that's also a problem. Now, we're not going to keep going back to, doing harm. I'm not going to go there. But what I'm saying is that with the understanding of the value of gamma gain, you can get the patient better faster. You are relating to them that your level of education is, right? You've got this depth of understanding. And when you yourself have experienced it, and you're empathizing with the patient, you can say, look, I know your knee hurts, but to get you over the curve into faster therapy, I need you to move faster. Now you have a rationale, a scientific medical, biomechanic, physiological rationale. Because of understanding gamma gain, you can now say, look, I know it's going to be uncomfortable. Let's put a TENS unit, or let's put some vapocoolant, or whatever. Let's put a hot pack, or whatever it is that you have to do to get them through the pain part, right? Let's hit it with a low-level laser. Whatever it is that you're going to do, they can now, we say, quick, right? You get that quickness going. The gamma gain is being educated into the movement pattern.
Yes.
They get through the therapy faster.
And the brain pays attention to, as well as the muscle fibers, the change in what? Speed.
Exactly. So the point is that when you change anything that's in a system, so we're saying, that's why we said systems based, right? Anything in the system. So when he changes his corticospinal intention to be faster, the proprioceptive feedback is faster.
Yes. It has
Right?
to go through that loop faster.
Right? And then the correction coming from the mind into the movement is also faster.
Exactly.
So by understanding the value of gamma gain, you actually have the reasoning to encourage the patient to move with that quickness, move with that suddenness, because you know when that happens that the core is being recruited more completely and more fully,
Yes.
right? And then if, of course, the reverse is, if you go slow, everything's just going to fall apart.
And the brain is going to pay more attention to pain versus the movement.
Exactly. Yeah, we've said that before too.
Yeah.
So in our discussion about gamma gain, we could say that the quality of the drill or the treatment determines if gamma gain or gamma is triggered, right, or not. And if it isn't, the treatment outcomes are delayed. I'm going to say incorrect, and I'm going to say inappropriate, and that's harm. Because if you know it exists and you know it's something that can speed things up,
Why are you doing it?
why wouldn't you if you could speed up their care, right? So we could also say that they're not addressing the faulty movement pattern at the same time, or because
Which is that cause going back to the previous points we made, addressing the cause, which is that faulty motor pattern.
Right.
Yeah.
Right. So attempting to treat the cause. So we talked about that in the therapeutic rationale. That was number 2, right? So I'm just going to say there's a possibility that we're actually creating potentially a faulty movement pattern within the therapy itself.
Yes.
The therapy becomes creating a faulty movement pattern because it does not address gamma gain.
Yes.
So, I don't know, what do you think about that?
We can literally go on forever about this, the topic, because we haven't even touched on the most prime or optimal biomechanically optimal position for gamma gain and getting into core neutral and how they fire and how the muscles are properly toned and distribution of weight. So that's even in itself is a whole nother video.
Well, yeah, we'll have to do like a part 2 or a follow-up, so that you'll understand how to institute gamma gain rich therapies, right? So we're not going to tell you this, you do this for bicep tendonitis, you do this for medial meniscus injury. We'll discuss it from a more universal point of view. Systems based, right? So and we've said this before too, understanding therapy from the point of multiple overlap to any part. So don't learn this drill for this drill for this drill, and have this huge laundry list of drills. Get it down to the top 5 and have the patient do a whole body experience and address like everything in the whole horseshoe, like lower extremity. We've talked.
Keep it simple, stupid. KISS.
Right.
Keep it simple.
Yeah. Or keep it simple, sweetheart.
Yeah. So, you know.
Yeah. Okay, so I'm going to say we're going to have to do part B, right?
Yes.
And thank you for joining us, and Dr. Forrester, Dean,
Venzel.
and we'll see you again soon.